Good morning. I've been looking forward to coming and speaking here. This will be the first time I'll be presenting in front of a group that's not primarily leprosy. So our lab has been looking at are soil-transmitted helminth co-infections relevant to leprosy clinical care and outcomes. These are the two maps for distribution of soil-transmitted helminths and distribution of leprosy. And you can see that there's a great deal of correlation. In fact, 94% of all annual new leprosy cases are diagnosed within soil-transmitted helminth populations. The remaining 6% are primarily immigrants that come from those areas. Leprosy, a little bit of background, is caused by Mycobacterium leprae. It can be treated with multi-drug therapy for 6 months, PB cases, or up to 2 years, MB cases. This is bactericidal, but doesn't necessarily clear the residues of the bacteria from the affected tissues. Mostly that is within skin and peripheral nerves, cool temperature sites. Neuritis can result in disability development, primarily seen in the eyes, hands, and feet. It's a chronic granulomatous disease across the immunological spectrum of clinical presentation. I didn't know if you were familiar with leprosy. In some patients, there's a polar Th1 or cellular response with inflammation. This is capable of providing some growth control for the M. leprae. In other patients, however, there's a polar Th2 antibody response, primarily non-inflammatory. M. leprae growth is mostly uncontrolled. Therefore, those patients will have more diffuse infiltration of the bacteria. Also in leprosy, there can be patients that are anywhere between the poles, and their immunology can change at any point before, during, or even years after treatment. Leprosy reactions are immunological complications that occur in up to 30 to 50% of leprosy cases at some point in time. They occur in response to either the live M. leprae that's there or the residual antigen that is left maybe even years after treatment. There are two main types of leprosy reactions. One is an upgrade in Th1 or cellular immunity, and the second type is thought to be more a humoral complication, but both actually are very poorly understood. They're unpredictable. They're associated with sudden shifts in immune response. It's not understood why people go into sudden shifts. It's just known that it happens. So you could have a patient who's fine one day, they've been treated for leprosy, and then suddenly they come in and they say, my hand is getting weaker. And the reason is they have either they have residual antigen or live M. leprae, if they haven't been diagnosed, still in that nerve, and the immune system has suddenly come up and is attacking the bacteria within the nerve and causing nerve damage. Okay? It can be acute, chronic, and sometimes recur for years in these patients. Because both of these leprosy reactions can be associated with neuritis, leprosy reactions are the main factor in leprosy disability development. Okay? So in other leprosy helminth co-infection studies, they've shown that chronic helminths suppress Th1 immunity in people. This has been shown in HIV, malaria, TB, allergy, and it establishes a generalized Th2 bias. Okay? There have been a couple of studies published from Brazil that demonstrated that leprosy patients that had chronic soil-transmitted helminth co-infection more often had developed higher bacterial loads or a higher BI. So the theory is that chronic helminth infection is pushing more towards the antibody response, Th2 response. This is allowing more uncontrolled growth of the bacteria over time. So I've been working at Anandaban Hospital in Nepal since 2007 around clinicians, and I've seen within an endemic context, dewormers are handed out very commonly. So commonly sometimes it's not even written down in the charts. You go to a medical camp, it's handed out. There are the mass drug distributions going door to door, handing out anti-filariasis drugs along with an albendazole. And so as an immunologist, I thought, but what happens if a leprosy patient has had their immunity suppressed for years to allow leprosy bacterial growth over time, but then the worms are removed? The immune system's going to come up, but by definition, that sounds like a leprosy reaction. So how to prove this? Okay, so this also raises several questions. Could helminth co-infection immunosuppression be increasing the risks of negative leprosy outcomes in patients? Is it allowing more bacterial growth that sets patients up for a leprosy reaction that then results in more disability development? Is it obscuring leprosy biomarker detection by muting signals or obscuring the immune signals in the blood? And would that then be hiding household contacts from early detection if we're trying to apply diagnostics? So we performed an investigation amongst our Nepalese patients. We just did detection and observation. We didn't tell the doctors to change any of their treatment because this was all based on theory, and we just wanted to get a view of what was happening. We screened the stool for helminths using routine microscopy, but also incorporated real-time PCR to look for 4 endemic species in Nepal: Ascaris, Strongyloides, Encyclostoma, and Necator. We also collected blood for immunoassays, and we monitored clinical outcomes. So as you could expect, from the stool smear, out of the 145 patients, only 4% of them actually demonstrated evidence of one of the helminths. We looked at eosinophilia in about 42 patients. Only 35% of them had eosinophilia, but only 2% overall actually then correlated with presence of helminths. When we applied DNA detection, however, 55% of the leprosy patients were infected with one or more of the helminths, which are then broken down into each of the next 4 columns. Okay? So then how do we want to look at this helminth information alongside common leprosy indicators or descriptors? So there's gender, PBMB, which is deciding how to treat the patient based on signs of leprosy, bacterial load, negative or positive, if it's detected, whether they have a reaction or not, and then I also broke it down into different types of reactions. So in this graph, I've color-coded gender, male, female. What percent of patients? Colored version, do they have soil-transmitted helminths? Clear is clear of soil-transmitted helminths. Between males and females, you don't see much difference, 50-50. PBMB, not much difference. BI positive, not much difference. But when we came to reactions, there was a significant difference. And cases reporting with soil-transmitted helminths absent were significantly more likely to be in leprosy reaction. This fits the theory. Their immune system, in the absence of the worms, is coming back up, and this is maybe contributing to them going into leprosy reaction. When we tried to break it down into individual forms of reaction, we had lower patient numbers. There was no statistical significance yet in this study. So then what I did is I pulled out from those 145 the 96 cases that were just brand new cases being diagnosed with leprosy. The ones who did not have a reaction, the bulk of them, so no reaction, were positive for the helminths. Conversely, those who did have a reaction, complete opposite. The bulk didn't have the helminths present at the time that they came to the hospital and presented with leprosy reaction. So again, cases reporting with helminths absent were significantly more likely to be in leprosy reaction. So this was a smaller number study, or preliminary, but I was able to break down the burden of the helminths based upon the DNA level. So there's the 4 different species that we investigated, and based upon the DNA that we were able to detect, we could assign high, moderate, or low. Here is a control, the group of patients who had none of these 4 species. You can see the bulk of those who didn't have any of the 4 species were in leprosy reaction. If we go to Ascaris, there were 27 patients, 78% had single species. As you see the number of patients in one of the categories increases, you start to see that flip. The bulk of the patients without the bulk of the patients who have the worm infection do not have reaction. And that was significant in Ascaris. We had lower numbers here. I just drew a line at 5 because that seemed to be an arbitrary number that we started to see the trend show up in this group. But here in ancylostoma, in the moderate burden level, 82% did not have reaction. However, 85% of those with ancylostoma had more than one species. So it was significant. So some other notes. The high lepre load was not significantly associated with soil-transmitted co-infection. This is different from the Brazilian study. They were able to show high bacterial load and co-infection. However, why did we not see that in Nepal? Nepal, since 2003, has been having mass drug administration through an anti-filariasis campaign. Secondly, leprosy is a long-term pathology. The bacteria and what you diagnose by biopsy is going to remain there for a good bit of time. You can give them a dewormer and the worms are gone. So worms are a transient type of infection in comparison to leprosy's long-term type of infection. So therefore, at the point at which we receive them when they've come to the hospital, they may have been dewormed of the original or the long-term helminth infection that had helped promote the growth of the bacteria. When we tried to ask the patients very gently, do they remember taking a dewormer pill? We had to be very careful because it was government or WHO programs, so we didn't want to make them suspicious of any sanitation programs. So we just asked, did you have any stomach problems in the last year? Do you remember taking anything? 77% of them said they'd either never taken or didn't know if they'd taken anything in the last 12 months. However, 10 of the patients said, yes, I did take a dewormer in the last 3 months. Out of those 10, 8 of them had reported with reaction. Now this is anecdotal because I don't know how many people did or didn't take it. It's self-reported. We don't know who didn't show up at the hospital, didn't have a problem. But it is an interesting trend. There were also trends in some of the other categories, but because this was only 145 patients across different types of patients, we need larger numbers and maybe it'll approach significance. So what do we show here? That within a co-endemic population, 55% of the leprosy patients had one or more helminth co-infections. Patients that had helminths absent were more likely to be reporting with reaction. Now, deworming is not standardized in leprosy care. You can talk to different doctors, and some of them say, yes, I give a dewormer to every leprosy patient upon diagnosis. Some of them say, oh, well, if the patient says they're having stomach problems, and some, well, sometimes, or maybe not. This is across all these leprosy endemic countries, okay? And also, it's very interesting. Leprosy reactions are generally diagnosed, depending on the country, at the time of diagnosis because the leprosy reaction symptoms drove them to the hospital. But the second most common time for a person to have a leprosy reaction is during MDT treatment, during the first 6 to 12 months of getting leprosy treatment, which is also the time many of these patients are coming from extreme poverty or not very much health care access. So actually, it might be their first time to get comprehensive health access, and they may be getting dewormed. And so we're theorizing that may be associated with why so many patients do experience a leprosy reaction maybe within the first year of treatment. However, this study did not yet demonstrate clear cause and effect relationship. So we applied for another grant with the Leprosy Research Initiative, and we were able to get 52% funding, and we have that study now in progress, and we're collecting samples. We have larger patient numbers, plus we've included household contacts. We're screening for all endemic soil-transmitted helminths that are in Nepal, which means we've been able to add, through some new tests, trichuris, tinea, and filariasis. We're going to perform blood immunoassays and urine metabolomics. And like you were mentioning about handing out pills and mass drug administration and rapid risk for reinfection, we tried to think what we could do alongside. So we're doing WASH training with each family and household to try and reduce their risk of reinfection in the context. This is, though after the Nepal earthquakes, this has also been challenging for their population. It's very difficult. But we are performing follow-up sampling for immune reconstitution changes that may be associated with the clinical outcomes. So what are the implications for these complicit NTDs? And there may be partnered relevance for eliminating them. How do we achieve elimination amongst persistently endemic populations? Because there's populations affected by leprosy that they have been giving antibiotics, and the disease does not disappear. Treatment of detectable disease and consequences, good, we need that. But secondly, we need to probably pursue development supportive of healthy host immunity, good sanitation, hygiene, nutrition, housing, and sustainability. As those things come in development, what would be the potential relevance for leprosy in that transition? According to what this shows, existing subclinical leprosy cases may develop clinical symptoms or complications upon immune reconstitution. Conversely, those who've been exposed in those environments, or maybe early cases, could begin to more sufficiently resist or self-heal before they develop clinical disease. And then I would like to thank the people who have been involved in this study. So there's the Leprosy Mission Nepal, where I work, and the Leprosy Mission England and Wales, which is the office here that helps support us. The Leprosy Research Initiative that's helping to support our new trial. And then the hospital staff, our medical director, dermatologists, and the lab staff, and Dr. Peter Nichols, who's helped us with statistics. So thank you. Dhanyavad. Any comments or suggestions? We do that later, yes?